We're now going to be taking a look at disorders of cardiac function, heart failure, and circulatory shock. As we look at disorders of cardiac function, we're first going to examine coronary artery disease, or CAD. This is when atherosclerosis affects the coronary arteries, or those that perfuse the myocardium of the heart. Atherosclerosis in the vessels inhibits their ability to deliver oxygen and nutrients to the myocardium. And wherever we have the atherosclerosis downstream, the muscle will be affected by myocardial ischemia, so not having as much oxygen as necessary, and necrosis. Since this disease is atherosclerosis, the risk factors are the same. So for example, high blood pressure, dyslipidemia, tobacco use, obesity, and diabetes all raise the risk for coronary artery disease. Restricted blood flow to the myocardium can cause angina. Angina is severe chest pain that can radiate to the neck, jaw, back, and arms. It's caused by a decrease in blood flow to the coronary arteries that results in ischemia. And this ischemia is transient, and it does not cause the death of the myocardium. Episodes generally last between 15 seconds to 15 minutes for a patient. And the pain comes from a shift in metabolism. So the heart must have energy to keep pumping. And if there's not enough oxygen, it's going to switch from an aerobic respiration to anaerobic. And that anaerobic respiration generates lactic acid and causes a drop in pH. So the tissue becomes acidic, and that's what causes the pain. Angina is important to CAD because it's the main symptom of CAD. There are two types of plaques that can develop in CAD, and these give rise to the outcomes for the myocardium. So the first is called a stable or fixed plaque, and that means it's not ruptured or moving, it's just stable. This causes what we call stable angina, which is just an obstruction of blood flow. Stable angina causes an ischemic episode with exertion or effort, like exercise, shoveling snow, going up the stairs. An unstable plaque can rupture, and that can cause a thrombosis or a blood clot. This can occlude a vessel. So here we can see a thrombosis here. So this can occlude a vessel, and when it does, the outcome can be a myocardial infarction or a heart attack. Unfortunately for the heart, CAD leads to changes that further cardiovascular disease. Depending on the area affected by the ischemia, it can generally lead to an impaired wall and ventricular function. This is going to decrease the heart's contractile force and decrease cardiac output because stroke volume will decrease and our end systolic volume is going to increase. The decrease in cardiac output will increase the sympathetic nervous response and increase the heart rate and blood pressure. Now, unfortunately, this increases oxygen demand on the heart again, and that can lead to more pain and angina. So the angina caused by CAD can be treated with nitrates. Those cause vasodilation and increases blood flow and decreases the workload on the heart. There are a number of diagnostic tests to diagnose CAD and a number of other cardiovascular diseases. So electrocardiography, or ECGs, record the electrical potential differences during the cardiac cycle. And changes in the ECG during episodes of angina can lead to a CAD diagnosis. An exercise stress test is when an ECG is done during a period of exercise-induced stress on either a bicycle or a treadmill. We have the patient hop on, and then we can do an ECG to see how that stress is affecting the heart. We can also do perfusion imaging with a stress test, and that can show areas of decreased perfusion and ischemia because of occluded vessels. And then we can also do an echocardiogram, and that's still the most common test to examine the structure and function of the heart. What that is it's an ultrasound that can show the structure of the heart, and it can even show blood flow. Many people have heard of the term bypass surgery, and what that is it's coronary artery bypass graft, or what we call CABG. People are referring to this invasive treatment for coronary artery disease, and it can be used to treat coronary artery disease and also prevent myocardial infarctions. So this is a surgical procedure which uses a peripheral artery or vein. Normally it's taken from a limb, and it places it on a main artery, and it literally bypasses the coronary artery with a plaque or an occluded blood vessel, and it restores blood flow downstream of that blockage. So you might hear people who say they had a double or triple or quadruple bypass. And what that means is it's the number of bypasses that are put in place to try to restore, you can see triple, quadruple. So the number of bypasses put in place to restore that blood flow. A result of CAD can be a myocardial infarction. By definition, a myocardial infarction is the death of the myocardium from a total occlusion of any artery and the failure of the tissue to perfuse and get oxygen and nutrient delivery. It's a type of acute coronary syndrome, which is a classification for thrombolytic coronary artery diseases. So it's called MI for short, and it's the leading cause of death in the US. Here again, because it's mainly caused by CAD, the risk factors are similar. Other causes of myocardial infarctions are thrombosis, platelet aggregation, or coronary artery stenosis or spasm. So we're going to take a look at the pathogenesis and mechanism of a myocardial infarction. So the first step is that an unstable plaque is going to rupture or occlude a blood vessel. And we're going to see a switch from aerobic to anaerobic metabolism. And we'll have a buildup of lactic acid, and that's generally what's going to start to cause pain in the patient. As the cardiomyocytes do not receive the oxygen that they need to keep working, we're going to see death of the tissue. And when the cardiomyocytes die, there's a decrease in contractility. As the contractility decreases, there will ultimately be a decrease in stroke volume and a decrease in cardiac output. The decreased cardiac output is going to decrease blood pressure, and the baroreceptors are going to pick up on that decrease in blood pressure, and sympathetic stimulation will be activated to increase the heart rate and increase our peripheral vasoconstriction. So now we're going to have an increase in afterload as well. So these mechanisms in place to try to fix the blood pressure problem ultimately increase the workload on the heart and the oxygen demand. And so it's sort of this bad feedback mechanism in place. So the more oxygen demand, the more the heart's going to work. And here we are with these blocked vessels. Those muscle cells are not going to get the oxygen that they need. So the size, location, duration of the occlusion, and whether there's any collateral circulation determine the effect of a myocardial infarction. If the left side of the heart is affected, it can lead to an impaired left ventricle and decreased cardiac output to provide for the systemic circulation. There can also be ventricular fibrillation, which is a major cause of sudden death from a myocardial infarction or heart attack. The right side of the heart houses our SA and AV nodes, which were part of the heart's conduction system. If those are damaged, then this can lead to an arrhythmia. The right side of the heart is also involved in venous return, and venous return can be interrupted as well. The area of tissue that dies during a myocardial infarction ultimately becomes scar tissue, and it's no longer muscle tissue, and so it cannot contract. A myocardial infarction then ultimately will decrease the heart's ability to contract, so it affects contractility, cardiac output, and blood pressure. So there are compensatory mechanisms that are going to be activated to try to maintain cardiac output and blood pressure. So those include vasoconstriction, an increase in our heart rate, renal retention of sodium and water. Unfortunately, those mechanisms in place are going to increase the workload and oxygen demand on an already weakened heart that was unable to meet oxygen demand and supply its cardiomyocytes with the oxygen necessary to function properly. The diagnosis of a myocardial infarction is based on symptoms, ECG findings that can show issues with conduction, cardiac biomarkers in the blood. So these are proteins specific to cardiac muscle that get released into the bloodstream when the muscle dies, and echocardiogram that can show heart wall irregularities. Myocardial infarctions are treated with rest and also drugs to help treat the effects or cardiovascular disorders that put someone at risk for a myocardial infarction. So antiarrhythmic drugs or a pacemaker can help to reestablish a proper cardiac rhythm if that's necessary. Anticoagulant and antiplatelet drugs help to decrease the risk of a thrombosis. Beta blockers decrease workload on the heart by blocking the sympathetic nervous system stimulation. And cholesterol-lowering drugs treat hyperlipidemia that can lead to atherosclerosis in CAD. And also diuretics will decrease water and sodium retention and help to lower blood pressure. We're going to switch gears now and look at cardiomyopathies. These are subacute or chronic diseases of the myocardium. They can be caused by genetics or acquired by risk factors like hypertension, myocardial infarction, heart valve disease, metabolic disorders, infections, or even drug use. And there are three main types that we can see illustrated here. The first is a dilated cardiomyopathy, and this is where the left ventricle enlarges and cannot effectively contract to pump the blood. And this is commonly caused by CAD or a myocardial infarction. The next is hypertrophic cardiomyopathy, and that involves the thickening. Here you can see a thickening of the heart wall right in here. We especially see it with the left ventricle, and it ultimately makes the chamber smaller. So this causes an abnormal ventricular filling and a decreased stroke volume. Hypertrophic cardiomyopathies are seen in the young, and it generally has a genetic etiology. And the last is called restrictive cardiomyopathy. And here, the heart loses elasticity, so it does not expand well to fill with blood. This etiology is idiopathic. So some individuals are asymptomatic, others can experience a shortness of breath, swelling in their lower limbs, cough, fatigue, dizziness, or pressure in the chest. An arrhythmia is when electrical impulses in the cardiac conduction system fail to coordinate, and that causes the heart rate to increase, decrease, or even have an irregular rhythm. It's important to remember how the conduction system of the heart works. There are autoarrhythmic cells in the SA node that start an impulse or an action potential by moving ions across their cell membrane. That impulse will travel to the AV node where it pauses, and then it travels down the bundle of His into bundle branches and then into the Purkinje fibers that wrap around our ventricles. As the cells depolarize, it's going to cause a contraction in the myocardium. When talking about arrhythmias, it's important to remember the electrical terms associated with contraction. So an action potential is the change in electrical potential associated with the movement of ions across the cell membrane. So you can see at rest, a cell is generally negative in its cytoplasm compared to the extracellular space. Sodium ions with their positive charge can move into a cell, and when that happens, we call it depolarization. The depolarization of cardiomyocytes leads to the release of calcium in the sarcoplasmic reticulum, and that triggers the muscle cells to contract. After that depolarization, a wave of potassium starts to exit the cell, and remember, potassium has a positive charge, so it takes that positive charge with it. And so as it does so, it reestablishes a negative potential in the interior of the cell, and we term that repolarization. At the bottom of the picture here, we can see these measurements of action potential in a cardiomyocytes. So here you could see, if we measure it, we're looking at an action potential. So A cardiomyocyte can start in a rest state and quickly depolarize as sodium channels open and sodium rushes into the cell. So we're going from a negative voltage to a positive one. Then it starts to repolarize and plateaus. So this is different than nerve and skeletal muscle. This repolarization in cardiomyocytes has this plateau because slow calcium channels open. This calcium is used for the contraction, but it also gives prolonged contraction. Repolarization completes as potassium continues to exit the cardiomyocytes. In an ECG, we can measure these electrical changes. So up here is an ECG. When you read an ECG, we call the different waves in it by different names. So the first wave is called the P wave, and that's detecting depolarization in the atria. Next, we have what we call the QRS wave, and that's picking up depolarization of our ventricles. Then the T wave is picking up the repolarization of the ventricles. Now, the atria do repolarize, but it's not detected by our instruments because the signal from the ventricles wipes it out. This is a typical ECG tracing. So somebody who has an arrhythmia, their ECG trace will vary from this typical tracking pattern. Interestingly, not all arrhythmias are pathologic, and they can occur in healthy hearts. For instance, some people have an ectopic pacemaker or an excitable focus outside of the SA node. If there is sympathetic nervous stimulation or the person drinks a lot of caffeine, that can lead to a premature contraction because of that focus. There are many causes of arrhythmias, including congenital defects, degeneration, myocardial ischemia, infarction, scarring, CAD, hypertension, hyper or hypothyroidism, fluid and electrolyte imbalances, and even drugs. Why arrhythmias can be detrimental is that they can affect the heart's pumping ability and therefore cardiac output. So arrhythmias are classified based on their location, either in the atria or ventricle, and their effect on heart rate. So tachyarrhythmias, being the heart rate will be above 100 beats per minute, which decreases that fill time of the heart and it decreases cardiac output. And bradyarrhythmia is a slow heart rate, less than 60 beats per minute, and that can decrease perfusion of our important organs. Symptoms include fluttering in the chest, a racing or slow heartbeat, chest pain, shortness of breath, fainting, and sweating. Here are some ECGs to demonstrate the different types of arrhythmias that we can have. And we're not going to go into a lot of detail, but I just wanted to show you a couple examples so you could see how the ECG traces look different. So at the top, this is an atrial flutter. This is a type of tachycardia in the atria with the atria ectopic tachycardia rate from 240 to 450 beats per minute. This can have serious complications like stroke. The bottom here, this is atrial fibrillation, which is less organized than atrial flutter. It's also associated with a rapid heart rate that gives rise to an irregular rhythm in the ventricles, and stroke again is a serious side effect.